So for pediatric emergencies, it's probably going to be split into a few like video times because it's a lot of information, and I just don't want to bore you all to tears with it all. Okay, so when we talk about those age categories, we're talking about these 5 specifically. Anything above 18 is considered an adult for the purposes of medical like categories of people. Newborns we talked about just on Tuesday. Infants, remember, is up to 1 year old. Toddlers, they say, is 1 to 3 years. Preschool is considered as 3 to 6. And then what they call school age is 6 to 12 years old. And then adolescence is from 12 on up to 18. So these are real general categories. And these are words that you probably heard applied to other things, like adolescent is sort of a basic word. But when we talk about it in the medical sense, or what we do with as an EMT, this is what you need to keep in mind, because they may have questions on the National Registry asking something, and you need to know what age range it relates to. If they're asking about a 12-year-old, you need to know like where that falls on the ranges so you can properly answer the questions. Because we're going to have ranges of everything in terms of like vital signs and stuff, and it varies based on age. Okay. So obviously there are some differences in a lot of different ways: psychologically, anatomically, physiology. I can't say that into an adverb, but physiology, there's going to be changes as well. And you need to make sure you understand those differences. Like I said, there's this big chart. I think we're going to get to go over it some in the PowerPoint as well. Y'all should know this. Maybe you remember it from last year, but a child's head, remember, is substantially larger proportional to their body than an adult's head is, larger in every way. So, I mean, you see babies born, like they've got relatively really tiny necks and bodies and everything. Their head takes up, I think it's about a fourth of their entire body length. Like their head 4 times would make up their entire body length. When you get to be an adult, the ratio is definitely smaller than that. It's like 1/6 of your entire body or 1/8 or something. I don't remember the exact numbers, but they should be in your book. Because of that, you have a lot of other things that are happening. So the head is not only like longer and everything, it is also deeper proportionately, meaning going farther back. The skull is a lot more round in the back. Your book has a really good picture of this. This child is laying on a towel in order to have the appropriate kind of like airway opening, because if they didn't have something to prop their shoulders up, the extra like rounded part in the back of their skull would kind of be pushing their head forward and down. And so instead of the airway being open, it's going to be more collapsed. And that's just because of their head shape difference here. Also, going alongside of that, with that airway, the respiratory system, they have a smaller nose and mouth proportionate to everything else. Alongside that, they have a larger tongue. So the tongue is larger tongue proportionally to the mouth, fitting inside of a smaller mouth, means the airway is much more easily obstructed with the tongue. It's also easily obstructed with other things, because the trachea overall is narrower. That's why if you've ever been a babysitter, you have to be really, really careful about what you feed kids. You can't feed them like whole grapes or anything round or large. You have to cut the bites up fairly small, just to make sure it's not something like a grape is like the exact size of a child's windpipe. So if they eat a whole grape and they didn't chew it properly, it fits perfectly. In a really bad way, perfect in a bad way, and you don't want that. So be aware of the sizes. Not so much for the babysitting side, because that's not what we're gearing y'all towards, but be aware of that size. Along with being narrower, there's also less cartilage and it's less developed. So it's narrower and it's easier to close off. Our windpipes stand up to a whole lot more as adults than a child's would. That's why with the posture thing, like this, tilting their head forward like that would potentially be enough to close off or partially close off an airway, because it's bending sort of in a way that an adult's wouldn't, or wouldn't be affected by as much. Like I said, in general, airway structures are just more easily obstructed. It's a lot easier to have a problem with children. Also, children aren't very good at swallowing things properly or chewing things properly, so they'll like inhale food or stuff, whatever, they put everything in their mouths. So you're probably going to have more opportunities for stuff to be there to obstruct the airway that's already more easily obstructed. As far as the chest and abdomen, they are more elastic in younger patients, meaning just that they move more. Children breathe not just like with the diaphragm like adults tend to do. They breathe with their entire chest. You see a lot more breathing movement because their ribs are just a little bit more flexible, and so you kind of see their whole chest move. You also see their abdomen move. They're abdomen breathers. They're using their diaphragm and everything so much that they're actually, when they're breathing, like it's like air is filling up and pushing the diaphragm even farther out, so you see their tummies rise as the pressure changes inside of their bodies. Everything about children is more fragile, but also more elastic. And so you're going to see more stuff from the outside that may be a little bit more obvious. They're less protected because of that. They don't quite have that same kind of rigidity of bones that we do. The same muscle and fat and everything like that to kind of protect our bodies. They're much more vulnerable to stuff because they're much less protected. Body surface-wise, okay, so overall, thinking about a kid, they have more body surface proportional to the volume inside. This is like a physics and geometry type thing. If you take like a sphere, a smaller sphere has relatively more of an even proportion in terms of the volume inside and the surface area around. But as it grows, the volume inside is growing at a much, much faster rate than the surface area because I don't remember what the... does anyone remember what the equations are for those? What's up?
Volume surface area.
Yeah, volume increases exponentially larger than surface area does. I just don't remember what the exact formulas are to calculate them. But exponentially larger. So as something is getting bigger, that surface area is getting relatively less. Okay? Same thing with adults. Same thing with adults and children. So children are relatively smaller. That means their surface area is relatively more compared to their volume than adults. Does that make sense? I'm trying to put the parallels, but basically children have more surface area. For the same amount of volume they have more skin, okay? So what happens with our skin? What can happen with our skin? Mumble, mumble, mumble. Okay, what happens through our skin? Moisture loss, right? Heat loss, heat gain. Everything. Your skin protects you all over, so you have more opportunities to get cut or sores or anything. The one thing we really do care about, though, is moisture and heat loss. Because with all that skin surface, there's a lot more opportunities for that evaporation to happen and potentially cause real issues. So they can't regulate themselves as well as adults can. They lose heat quicker. They get overheated faster. They get dehydrated a lot faster. You have to be really careful with kids. Okay, blood volume is different. Again, size-wise. A brand new newborn baby probably has about as much blood volume inside their body as a Coke can. Okay, which if you think about it is really, really small. They're offering some different examples of what you might see. Keep in mind, we usually consider that a full-grown adult has around 6 liters of blood. That's kind of the number we throw out. They're saying more close to 4 liters of blood for that particular type person, and it really does depend on the person. So when we do calculations in this class, we usually talk in terms of 6 liters, but be aware the number is going to be within a range. 4, 5, 6, maybe a little bit more, maybe a little less, depending on the person, depending on age, health, everything, a lot of options. And then obviously a medium-sized child is going to have a medium-sized amount of blood, like Goldilocks and the Three Little Bears, everyone's different. So no one is just right, but everyone is different, so be aware that it does change drastically. So in general, regardless of the age of the child, there are different tools or ways you can kind of approach each age range based on how that group is characterized. But in general, with any pediatric patient, you want to make sure to be very, very non-threatening. Identify yourself, your name. It's a good place to start. If you have a really difficult name, maybe make it easy for them. If your name is multiple syllables long or something they might not have heard, shorten it just a little bit. Just make it easy. My full name that I might go by to my mom and dad is Mary Tess. But to you guys, it's Mary. Not because y'all can't handle Mary Tess, but just because it's shorter, it's easier. And that's good enough for me. If I was dealing with a kid, I would say that my name was Mary or something equally short and memorable. Because I don't really care what they call me. I'll let them call me MT. It doesn't matter. I'm just trying to get something that they can relate to. And that's enough for me because they need to have somebody they can relate to if something's going wrong. If you're dealing with a child, You need to let them know that their parents are involved. That's very, very comforting for them. Whether their parents are nearby or maybe if their parents aren't there, you need to let them know, we've called your parents and they're going to come and help out, okay? Again, any age range, parents are the first thing they go to in terms of authority and protection and comfort. So don't just assume that the kid knows that the parents are going to be there. They need that extra reinforcement that we are involving your parents. They're going to be here. They're going to help. And that really does help the kid feel a little bit more safe. In general, always be calm around kids, especially if there's no actual life threats. You don't want to make things seem more manic than they are. Kids absorb so much of the way that they act and think and everything based on the people around them. That's why we have so many concerns about they were watching Miley Cyrus at the VMAs and now they're all going to be doing stuff. Realistically, they're getting their behaviors and things like that from their parents or from the adults that are directly around them, from their school-age friends. So if you're around them and you're screaming and seeming really hyper and scared and anxious, they're certainly not going to be calm in the face of whatever's happening. You need to be the one that sets the pace and is calm so they can take their cues from you. Get down on their eye level. Okay, it's a lot nicer to talk to somebody who's actually treating you like you're a person at their eye level versus talking down to them. Again, it's much more intimidating if they're having to look up at some big authority figure in a uniform that they don't know. A whole lot nicer if it's just down on your knees or sitting next to them or kneeling or something like that. Whatever you have to do to be a little bit more friendly. Especially if they're young, let them have some sort of toy or whatever they might want to feel comfortable. If it's an easy thing, if it's an easy fix, go ahead and let them have one. Some ambulances actually keep teddy bears, one or two, just in the big bin where they keep all the other blankets and things. Just on the off chance you have a kid in there, again, it's kind of nice to have something that seems sort of familiar. Even if it's not your teddy bear, at least it's better than no teddy bear. It's kind of what they go by. Okay, again, when you're interacting with them, you want to be friendly. Please smile. Kids are absorbing your mood and adopting it as their own. Be friendly, be calm, be as happy as you reasonably can be in terms of smiling, doing things like that don't seem threatening, that don't seem scary. If you have a look on your face, I don't know if y'all have seen these. There's YouTube videos of a woman was playing with her baby and interacting and smiling and laughing alongside, and the baby was laughing and smiling. And then the woman, it was an experiment type thing, but the woman stopped, no facial expression whatsoever, just stared at her baby. And eventually the baby's face, it was laughing and smiling and still kind of trying to play with its mom, and slowly it stopped. And its face went very still and silent, and then it started to cry. The mom wasn't making any face at it or be doing anything to hurt it or anything like that. But the mom was just no longer smiling, and that made such a difference for the kid. So be aware of that. Be careful in general about touching kids. Okay, again, you want to offer them that comforting presence, but especially if they are very, very scared about the whole thing, they may not want to be touched by somebody that they don't know. So touch them in a very non-threatening way. Touch them on their hand. Hold their hand maybe. Touch them on their foot. Don't touch them somewhere near their face or something that's going to make them feel uncomfortable. Just like we were talking the other day about OB-GYN emergencies, be very aware that, it's probably later on in your book, but this whole idea of potentially child abuse or sexual child abuse or inappropriate touching, as an EMT provider, you do have to be somewhat concerned with that. Just like teachers aren't really supposed to hug students, just be aware. You're there to help them, but again, people can and will get very, very emotional about something regarding a child. And sometimes they'll take that anger out on you by saying, oh, well, the EMT provider touched my child inappropriately and it made them scared and something like that. And it's really, really hard to prove or disprove that, but it is a big deal that we have to be concerned about. Be careful with touches. When you're dealing with equipment or anything, make sure you explain what you're doing in a way that the child can understand. So hopefully the parent is there and you can explain to the parent, I'm going to be... anything from I'm going to be taking your child's pulse to I'm going to be giving your child a shot, whatever. The parent can kind of help the child be comforted. But you do want to be careful about the language you use. If you tell a child, there are certain age groups that are very, very literal, like toddlers are very, very literal in terms of what you say. So if you say, I'm going to take your blood pressure, they literally think you're going to take something away from them, and it scares them. Find a different way to say it. I'm going to check your blood pressure. Or just say, I'm going to put this thing around your arm, and we're going to blow it up like a balloon. Okay? Find a different way to word things so that it doesn't freak the child out. Because if they think you're taking something away from them, well, gosh, who knows what's already happened to them. They don't need that extra stress. Again, let the child see your face. It goes along with the smiling, getting down on their level kind of thing. Stop occasionally and find out if they understand what you're doing or saying. Don't just assume that they're kind of getting it or that they're following along, because they probably aren't, depending on the age. So make sure you stop and say, do you understand what we're going to do now? Just give them a couple opportunities so they can feel like they're a participant and so they don't feel so overwhelmed by whatever is happening. And never lie to a child, okay? Has anyone in here ever gone to the doctor's office and the doctor's like, oh, this one hurt a bit when he gives you a shot? Yeah, that sucks, right? Yeah, you'd rather know if it's going to hurt. You'd rather know what it's going to feel like. At least I would. I'd rather not be lied to. Even if it is going to hurt, at least I can prepare for it. Don't tell a kid that it's not going to hurt. If it is going to hurt, if you have to do something that's going to hurt them, whether like splinting an arm or something, it's going to cause some pain in the process. You're going to try to be gentle, but it is going to hurt somewhat. So be honest and let them know. Try to be honest about what you're going to do. Just don't lie to them. It's not fair. It's not cool. If they ask something like, am I going to be okay? Or am I going to die? Or something like that. Or if they ask you questions about what's going to happen, again, be honest. Generally the answer is going to be, no, of course you're not going to die. We're going to do everything we can to help you. Don't say that you're going to fix it, because you can't necessarily. Don't say that everything's going to be okay, because it's not necessarily. But say that we're going to work and try to help you. Come up with words that will be comforting for them while, again, not lying. It's just, there's no point to that. It's not fair to the kid. Okay, along with dealing with a kid, every single time you have a kid patient, you're going to have adult patient by proxy, somebody else that you're having to deal with along with the kid. The care provider, grandma, grandpa, aunt, whatever, babysitter is going to need some support too. So depending what's going on, depending how bad it is, depending on how good that person is at dealing with a crisis, you may have any kind of reaction. They may be just totally okay and calm and comforting and awesome, and that's great, but not everybody is that way. You may see them trying to deny it. You may see them getting angry at you, angry at the child, angry at somebody else, crying, screaming, blaming themselves, feeling guilty. In general, you want to try to encourage, or hopefully maybe have your partner encourage any adults that are around to remember that we're trying to deal with the child here and keep the child calm. And hopefully that will kind of help them so that they're not screaming at you, how dare you be hurting my baby girl, blah, whatever. You want to try to calm the parent down as well. Make it a little bit easier, because otherwise it may actually interfere with the care of the child. The parent may get so distraught over what's happening that they're really not thinking clearly. Like maybe in their intellectual mind they know that what you're doing is not going to be making anything worse, or at the very least that you're doing your best. But at the same time, what they're hearing now is their child screaming in pain, and that's what they want to stop, and that's what they're going to just kind of do whatever they can to fix, even if it means they're actually getting in the way of you fixing something.
What do you do if you have an over-caring parent and you try to do something give them medicine and the kid's completely fine with it, they don't say anything about it, but the parent's no, you can't do that,
Okay, well, if you remember what we went back to with consent, the parent gives consent on stuff, meaning if you're going to give aspirin or something, fill in the blank random medication, if you wanted to give aspirin to the child and the child, they have no allergies and they haven't taken any medications that would interfere, and this would be the right thing to do, you're doing the right thing. If the parent comes in and says, no, you can't give that to my child, you can't give it to the child. Even if the kid says, yes, Mom, I want to take it. Because the parent is the one that legally has the right to consent or not consent to a given course of treatment. Yes. Now, generally speaking, the average good parent is not going to say no to something that obvious. Something like bandaging a wound or splinting an arm or something like that. Or even giving oxygen, giving aspirin. Generally speaking, the parent is not going to interfere like that. If that happens, you'd want to stop and explain to the parent really carefully, like so they know that they know what they're saying no to. You want to explain, look, I believe this is the best course. This is how we deal with this type of injury. We splint them in this manner. If we don't splint it, there's a chance that the bone is going to continue to move around in her arm and cause more bleeding and potentially make this fracture even worse, and ask for consent again. Now, if the parent still doesn't give consent, they don't give consent. Like, that's what it comes down to. If you think that a parent is interfering with their child's treatment to the point that they're actually endangering the child, that is when you call your medical control. At that point, it's out of your hands. You can't take the personal power to somehow say, no, I'm going to do this for you, you just go away. You call your medical control and you explain what's happening and that this is the scenario you're being given, and it'll be handled from there at a higher level than you. So usually, like I said, that doesn't happen. Usually the parent is able to see reason, or maybe there's another parent who can give consent. Like if the mother's really freaking out, maybe the dad's okay and the dad can kind of say, yes, you can splint the child, I'll talk to my wife, or something like that. You can also sometimes help calm the parent down by asking them to participate. So anything from, look, mommy's going to wear a mask on her face too, so you're both okay, kind of thing, to actually having the parent hold the kid while they're being splinted or receiving whatever treatment it is. Sometimes that helps. It obviously helps the kid because they're getting comforted by their mom or dad or whatever. And it helps the parent because they feel like they're somehow in control. Because that's what a lot of this is they feel like they can't control what's happening. And that's really, really distressing for a parent or a guardian. So give them a way to kind of get involved if you can. Let them ride on the ambulance if it's safe, if it's not critical and there's room. And hopefully things won't go too badly. I personally have never had a scenario where a parent has refused an acceptable course of treatment repeatedly. Like, I've had occasionally a parent say, wait, I don't want you to do that. And then I explain that, well, ma'am, I really need to give your child oxygen because she's having a hard time breathing. And I explain, like, what I'm going to put on the face. And then she's like, okay, well, you can do that then. That kind of thing. Does that answer your question? Yeah. We are going to get to, when you first said over-caring parents, I thought of child abuse, which if a parent seems way too caring, that's actually a sign potentially. I'll explain it later when we get to the section on child abuse, but we'll talk about that too. Okay, do you want to take a break briefly? I want to take a break. Okay, so when we're talking about assessing pediatric patients, children, we talk about the pediatric assessment triangle, and that's essentially what do we look at in kids to assess them. Because not every kid, it just doesn't show up the same way. Things that you see from adults to kids don't always look the same. Also, kids aren't always as good at being vocal about what's actually happening. They can't describe their pain as specifically or something like that. So this is what we start off with for patient assessment, kind of like we would deal with for ABCs, but it's specifically things we will look at, like diagnostic tools. The first corner, or the first side of the pediatric assessment triangle is appearance. And for this, we're talking about mental status. We're talking about whatever like body position and posture they're in, whether they're lying on the ground, sitting, whatever. We're looking at muscle tone. Overall, this is sort of the level of consciousness that you might like equate for an adult. But these are how you're going to see it, because when we talk about level of consciousness or like alertness for an adult, we're talking about asking questions and trying to get like good answers. Kids may not know what day of the week it is, stuff like that. This is the better way to assess a child. You're looking at, like I said, body position, muscle tone. That's like dealing with consciousness or not. And then also mental status, trying to maybe find out some stuff or trying to observe things, but you can't necessarily ask the same questions you ask of an adult. Work of breathing is just, what do they look like when they're trying to breathe? Do you see the tummy moving in and out? Do you see all those, the intercostals and all these other accessory muscles really working hard for each breath? Are they tripoding? Remember what that looks like? Like leaning forward, hands down, like forming the tripod kind of thing. Do they have their nostrils flaring? Again, opening, are they kind of like, do they look like sniffing the air, trying to get more air into their bodies? A child who's in respiratory distress, you're going to see them leaning forward, doing the tripoding, like hands on their knees, leaning forward, head up, like trying to get as much as they can in and all the accessory muscles moving as they're trying to breathe. Circulation to skin. So, I mean, pulse is important, but we're really looking here at skin color. What you assess for adults, but specifically for children, skin color and also capillary refill. It is not as good of a diagnostic tool on adults as it is on children. Capillary refill is a really, really good diagnostic tool for kids. So if you press the fingernail and in less than 2 seconds the color comes back to normal, it's a really good indication that the kid's doing okay, versus if it doesn't come back to normal, it's a really good indication that the kid's not doing okay, that they're having major circulatory difficulties. I don't know if we can watch these videos. We'll try. Yes. Oh, I think this one's terrible. If I remember correctly.
This is the Medicast Podcast Extra Slideshow. We'll be looking at the pediatric assessment triangle and some of the things that it can do to help you in your assessment of pediatric patients. So what are we talking about when we look at the pediatric assessment triangle? First of all, it's something you're going to use in your initial assessment, and it's easy to use. It's before you even get to the patient. It's non-invasive. You don't even actually touch the patient when using the pediatric assessment triangle, and that's one of the things that makes it so amazingly valuable for assessing pediatric patients, especially those very young patients who have a lot of strain or anxiety as part of their normal development. It's non-threatening because you can do it from a distance, from across the room, without ever approaching these patients, and it's really easy to do. Now, I'm serious. It really is.
Just in case you were disagreeing with him there.
The triangle
Mentally.
is based on you using 3 variables to determine whether you have a sick or not sick patient. And by sick or not sick, we really mean critical or not critical. Is this a patient that you're going to be really loading and running with, or is this somebody you can stay and play with, that old adage? But in pediatric assessment triangle terms, it's sick or not sick. The 3 variables are appearance, work of breathing, and circulation. And these are the 3 things you can actually assess very well without ever getting too awful close to the patient and before you start using your stethoscope or actually hands-on inspecting patient injuries. So let's look at appearance first of all. Appearance uses the acronym TICKLES, and TICKLES refers to tone, interactiveness, consolability, look or gaze, and speech or cry. And these are the things you can look at from across the room. You're looking at their appearance and their general interacting with the environment, their tone. You know, how are they responding to their providers? If they're sitting with their mother, and this comes to consolability, they're interacting with their environment. They notice you when you walk into the room. Are they easily consoled? Is mom able to calm them down? When they look at you, does their gaze seem vacant? Are they actually making eye contact and appear to be looking at differences around the room? You know, in a very young child, in a 9-month-old, 12-month-old toddler, you know, you walk in the room with all of your equipment, they are going to pay attention to you. And if they're not, that's an indication that something's wrong. Also, their speech or their cry. Are they using appropriate words for their age? Or is their cry extreme and seems pain and, again, inconsolable? These are things you can look at. What about work of breathing? Well, work of breathing is something else you can look at across the room. You can watch their rate of breathing. You can see what they're doing. Is their rate very, very fast? Even in pediatric patients, too fast breathing is a sign of problems. What's their positioning? Are they tripoding? You know, in a young asthmatic patient, are they having to sit upright? Are they supporting their shoulders and trying to expand the rib cage by propping forward on their arms? Do you visualize retractions, suprasternal retractions, or retractions if their shirt's off, retractions in the intercostal spaces, or along the clavicles? You can see that. nasal flaring, anxiety while they're breathing. Are they very anxious and upset and seem like they can't catch their breath? You can see all this while you enter the room. Finally, circulation. Circulation looks at just your general patient color. Things like cyanosis. Are they pale in color, ashen, or mottled? These are the things you're going to be looking for in these patients to see if there is indeed the onset of shock occurring. Remember, pediatric patients plateau and maintain their compensatory mechanisms for a long time. And when they do that, the problem is that when they get to the inability to compensate stage, they crash very rapidly. Rather than that slow downward slope you see in adults, you actually see a straight line and then a cliff in that graph. And we really want to make sure we get a head start on any signs of shock. And you can see that when you look at their skin color. So let's review real quick. You want to assess these patients when you come into the room. You can look at them as you walk up to them and do this review very quickly. You can actually look at all three aspects. You're going to be looking at their appearance, how they interact with their environment. Are they consolable? Is their cry extreme? Do they use appropriate speech for their age? These kind of things. How hard are they breathing? What's their rate? Are they working hard? Are they tripoding or using some other position to compensate? Are they very anxious? And finally, circulation. We're looking here at their color, their skin color. Are they cyanotic? Are they pale or mottled? Or in dark-skinned persons, ashen in appearance? These things can all lead you to believe and determine whether this child is sick or not sick. And that is the purpose of the pediatric assessment triangle. You'll find more information like this over at medicast.com and, of course, in the Medicast Extra program that's available for the...
Okay. A couple vocab-related things. Did y'all know what he meant when he said the words retractions and mottled? Do y'all know what those are? Okay, mottled is a particular like skin look that you might see, kind of like blotchy, patchy. So pale, and then maybe really like anything from like a reddish, pinkish flush to even more like a purpley kind of tone. It might be how your skin looks when you've like been out in the cold and you kind of like some parts are getting some color back, and so you see a little bit of color and like patches of white and whatever. That's kind of what it looks like. We can look up pictures probably. Also, retractions. Y'all know what those are. When he was talking about breathing, he mentioned you can look for retractions. Okay, so we talk about with breathing, most people use the diaphragm. Adults use, the vast majority of the time, use the diaphragm. But you've also got all those accessory muscles, like the muscles up here in your neck and around your collarbones, the muscles between your ribs called those intercostal muscles. And when you breathe, even though you're mostly using the diaphragm, you are somewhat using these to kind of help open up the airway a little bit more. People who are struggling to breathe will be using these muscles a lot more. Now in kids, because everything is more flexible with them, when that diaphragm moves down, that rapid, drastic change in pressure, remember the diaphragm moves down, that makes less pressure overall inside the chest cavity, that's going to suck every one of these accessory muscle areas inwards, just slightly. So we're talking about retractions, meaning when they breathe in, you're going to see like the skin between every rib kind of like suck in slightly. And when they breathe back out, it'll go out slightly. They're breathing so hard, they're actually really not using the accessory muscles. They're using only the diaphragm, and it is pushing so incredibly hard that the muscles just can't keep up. So they're just kind of helplessly moving along with the flow of air. That's what retractions is. And I can probably find a video of that for y'all as well later on. Okay, I don't know how much longer I want to go before taking another break. But primary assessment, let me check real quick here. Okay, we're going to talk about this next period. I'm just going to take this break now and we'll talk about it later.